my senior colleagues, and our esteemed judges. We thank you for your presence here today. We are really pleased to have you all here. So I'm Dr. Fasamade, and I'll be presenting on behalf of my group from Bagada General Hospital, and we're talking about determinants of diabetic neuropathy amongst diabetic patients attending our clinic. I'll be following this outline. We all know that diabetic peripheral neuropathy is one of the microvascular complications that we see in our patients, and we know it increases the risk of full torsades and eventual amputation. It does not only reduce the quality of life of our patients, it has profound economic effects on them, their families, and the economy at large. There are different methods of assessing peripheral neuropathy, but in our study, we used the quantitative method, the biothesiometer. And the objectives of this study was to objectively determine the prevalence of diabetic neuropathy among DM patients attending our clinic and to identify its determinants. It was a cross-sectional study. We did it over 5 months. We had 231 participants using a convenient sampling method. We collected information on their social demographic, anthropometry, HbA1c, FLP, and serum creatinine. We also calculated their EGFR using the MDRLD calculator. The biothesiometer vibration perception threshold was used, and we graded it thus. Grade 1 is voltage of 15 to 24, while grade 2 is volts greater than 25. This was analyzed using the SPSS 26. So our results. Most of our patients have type 2 diabetes, which is, we all know that it's quite common, and most of them are, 2/3 of them are females. Our mean age is 59.8 years, and the mean VPT score, VPT means vibration perception threshold. Our mean VPT score was 19.38, which was quite high. The prevalence of nephropathy, especially stage 3, 4, 5, was 16.7%. And the prevalence of diabetic neuropathy, both grade 1 and 2 together, is 61%. So this pie chart is just showing us the grading of our participants with diabetic neuropathy. We can see that it's only 38% that do not have neuropathy. We now compared some select cohorts. We compared males against females, and we found out that there was a trend that the males actually have a slightly higher VPT score, though it was not statistically significant. Then we compared those with HbA1c greater than 7 and those less than 7. We found out that the VPT scores were slightly higher in those with HbA1c greater than 7, though was not statistically significant. Then we compared type 1 and type 2 DM patients, and we found out that in type 2 DM patients, their VPT score was 19.63 compared to 10.18. This was in type 1 DM, and this was statistically significant. We did a correlation, and we found out that diabetic neuropathy was positively correlated with age, DM duration, systolic blood pressure, number of DM complications, and it was negatively correlated with income, level of education, and EGFR. Over 60% of our patients have diabetic neuropathy, which is higher than the pooled prevalence in Africa, which had 46, we reported 46%. And it's higher than the subgroup analysis in West Africa, which was 49.4%. What is this saying? Our patients are at high risk. In Yola, using the same criteria, the prevalence was much even higher than ours. It was 86.8%. We found out that DPN was associated with increasing age. So the older the patient, the higher the risk. The higher the BP, elevated blood pressure, duration of DM, height, creatinine, and other DM complications was associated with the risk of diabetic neuropathy, which is what is seen in other studies. There was a negative correlation between DPN and EGFR, income and level of education. So in conclusion, DPN is prevalent in almost 2/3 of our participants, which will predispose them to higher incidence of DM foot ulcers and subsequent amputation. Increasing age, low socioeconomic status or stature, long duration of DM, and presence of other DM complications, especially nephropathy, are significant determinants. So don't just use creatinine. Sometimes take the time to to calculate their EGFR. Once there's some EGFR is deranged, know that there's presence of peripheral neuropathy. The presence of peripheral neuropathy may signal the presence of other microvascular complications like retinopathy, and the prevalence of DPN and nephropathy are significantly higher in type 2 DM patients compared with our type 1 DM. These are my references. Thank you for listening.